Welcome everyone, good afternoon, to the final installment of our Spotlight webinar series on quality of care. Thank you all for joining us. We have a wonderful panel today to discuss the issue of financial incentives and how they can work to improve quality of care. We expect that we have with us today some of you who have been here for one or two of the previous webinars in the series, and some of you who are joining us for the first time. So I will mention that the webinar series has been inspired by a comprehensive study that the Observatory published in 2019, looking at the way different strategies can contribute to improving quality of care, and examining how these strategies are implemented in Europe and what we know about their effectiveness, cost effectiveness, and best ways for implementation. The understanding also being that different strategies focus on different elements of quality, but that if we want to improve quality as a whole, we need to combine different strategies and make sure that they are aligned and function together. So, in this, with this backdrop, we thought about this webinar series and how we can structure it, and so we based the idea on the concepts of the father of quality measurement and assurance, Avidis Donabedian, and so we had one first webinar on health technology assessment, looking at the structures, inputs of care. We had a second webinar last week on clinical guidelines, looking at how we can improve the processes of care. And so this week, we're going to look at the outcomes and how we can, by providing financial incentives linked to outcomes, improve the quality of care, or rather, if we can improve the quality of care with such measures. As with our previous webinars, we have a very specific way of doing them. We have a keynote in the beginning that will set the scene for the topic. And then we have 3 spotlight presentations that will come in from different perspectives to highlight different issues. Just before I move into introducing our speakers for today, a little bit of housekeeping. We have, as I said, an excellent panel of contributors, but we also want to hear from you all with your comments and your questions. And we ask that you put your comments and your questions in the chat. We have Erica Richardson with us, who is moderating the chat box, so we'll keep an eye on it. We won't be taking questions after each of the presentations, but at the end, we will make sure that we reflect your inputs back to our speakers and we discuss. And so without further ado, let me present who we have with us today for the final webinar of the Quality Spotlight. We have Wilm Quentin, who will give us the keynote presentation. Wilm is a senior fellow here at the Department of Healthcare Management at the Berlin University of Technology, Technische Universität Berlin, where I'm seated today for a change as well. Wilm is a senior research fellow here, and he's also the associate editor for the journal Health Policy, and has a long experience in researching payment mechanisms, among other things, and quality of care, and is one of the editors of the study that I mentioned, the comprehensive observatory study. So once Wilm has given us his keynote, we will go over to Kaia Kasekam from Estonia, who will give us the Estonian perspective, the Estonian experience. So Kaia is currently with the University of Tartu, but has worked with WHO, with the World Bank, and also in Estonia with the Ministry of Health and the Health Insurance Fund. So brings us a strong experience from that side. We then, after we've heard from Estonia, we move a little bit further away and we go to Robert Berenson in the US. For the US perspective, Robert is a senior fellow at the Urban Institute in Washington, DC, and publishing on care delivery and particularly Medicare payment policy. And he also served on the Medicare Payment Advisory Committee, so he brings us from the source the experience of if and how paying for quality or paying for performance or paying for outcomes, or whichever way you want to call it, works for improving care. And having Robert here is also the reason why we have the webinar at a different time today, because our usual slot at 12 noon would have been quite an ask for Washington. And then finally, our final spotlight, João Breda. We're very pleased to have you with us as well, João. João is the head of the WHO Center for Excellence on Quality of Care and Patient Safety, which was launched or was established last year in Athens, Greece, and yesterday launched one of its flagship initiatives on mental health. And so we're really looking forward also for that perspective from the WHO. So as you see, we have a star lineup, and for that reason, I won't take any more time with the introduction, but I would say we move to Erica Richardson for a very brief introduction of a poll question to engage our audience, and then we move to the keynote by Wilm. But Erica, first, over to you.
Thank you very much. Annalisa, if you could launch the poll, that'd be fantastic. So just a quick question, just to see where we are with you as an audience. And it's, as payments for quality mechanisms, how are they actually used in your country? And it's multiple choices, so you can tick 2-3 boxes. Are they used in primary care? Are they used in hospitals? Are they used in other parts of the health system? Or are they not used at all? So it'd be just useful for us to see where we are as an audience. If you could answer that, that'd be fantastic. Thank you very much. Thank you. Back to you, Dimi.
Thank you, Erica. Thank you very much. And I'm also looking forward to the results. And without further ado, we move to Wilm for his keynote. Wilm, you are one of the editors of the study on quality of care. You're also one of the authors of the chapter on paying for quality. Enlighten us, please. Over to you for the keynote.
Yes, thank you very much for the introduction. I'm happy to present about the pay for quality using financial incentives to improve quality of care, which is, as you mentioned, already based to a large extent, in fact, on the chapter on pay for quality in our book on improving healthcare quality in Europe. So if there are certain things that you do not understand during the presentation, or that you would like to really understand better and have another look at the tables that I will show and the figures that I will show during the presentation, please feel free to follow the link that Erica shared in the chat and to look at the chapter, which provides more depth and more time to look at what I will be presenting, most of what I will be presenting during this presentation. So the underlying rationale of pay for quality is really that traditional payment systems do not provide direct incentives for high quality care. The most existing payment systems, such as fee-for-service or capitation systems or DRGs for hospitals or global budgets, they are kind of playing with either incentivizing activity or trying to control costs, but they do not directly provide incentives for improving the quality of care or for providing high quality of care. And therefore, the assumption of pay for quality is that providers will improve the quality if they have a direct financial interest to do so. Because otherwise, currently, there is no interest really to improve quality of care. There is an incentive to either provide a high level of activity or to reduce activity, but there is no direct financial incentive to provide high quality care. And the proponents of pay for quality initiatives say that the intrinsic motivation, the non-financial incentives, are not enough to motivate improvement. And sometimes also people are frustrated by seeing that the same providers always perform poorly, and there's no punishment, there is no incentive or reward for those hospitals or physicians that continuously provide good quality of care. On the other hand, and pay for quality is a relatively contested area where people have different opinions, and also providers strongly often voice their opposition against pay for quality programs. Is that financial incentives may crowd out the intrinsic motivation of providers and therefore lead to adverse consequences, such as an exclusive focus on indicators that are measured, or an exclusive focus on certain indicators without taking into consideration the full continuum of care and all the needs of patients that are important in order to assure good quality of care. And as there is no generally accepted definition of what pay for quality means, for our book chapter we had to come up with a definition, and we said that pay for quality is defined by these two characteristics. On the one hand, performance of providers is monitored in relation to pre-specified quality indicators, and on the other hand, monetary transfer is made conditional on the achievement or improvement of the measured quality of care. And there's often confusion between pay for quality and pay for performance, or pay for performance is used often under the assumption that this is a way of improving the quality of care, but in fact, pay for performance often includes aspects of pay for quality by measuring certain indicators of quality, but often many P4P programs also target other dimensions of performance. So like there are additional incentives to use resources efficiently, or there are certain activity-based payments if there are certain areas of care where activity should be incentivized, and they are not exclusively focused really on quality of care, but measure other indicators as well. And this is the distinction between pay for quality and pay for performance. And for to understand the characteristics of pay for quality programs, it is useful to use a systematic framework that we have developed as part of our efforts for the quality book, to kind of systematize the characteristics of different quality strategies. And the characteristics of pay for quality in theory are that they may aim at improving effectiveness, safety, and/or responsiveness of care. So it may target all of these dimensions of the OECD framework of quality. It may focus on preventive care, chronic care, or acute care, or palliative care. It may also use quality measurement in terms of structure, process, or outcome indicators. It may target professionals, or for example, physicians or nurses, and/or organizations, for example, primary care practices or hospitals. And so in theory, pay for quality may have many different attributes, looking at all these different dimensions of care. And it is useful to use such a framework when comparing different pay for quality programs across countries. And then what we see is that in practice, pay for quality focuses more on certain areas of care, and characteristics of these programs differ across areas of care. So they are not the same. The indicators are different for primary care, for example, than for hospital care, and also the measures that are used to measure quality of care differ across different care areas. And so on the next few slides, I want to give you an overview of a few of all the pay for quality programs in primary care that exist in different European countries. And for our quality book, we tried to get a full list of pay for quality programs in different European countries, and we identified, in fact, 14 programs that exist in 13 countries, because there's one country listed here, France, where there are 2 different pay for quality programs in primary care. And the table shows on the one hand, and yeah, I guess you probably won't be able to take in all the information shown in the table now during the presentation, but it shows, and you can look at the book chapter afterwards if you are interested and want to better understand the content. But it shows that whether or not a program is implemented at the national level or at the regional level, whether it is voluntary or mandatory, so whether it mandates all providers to participate, when the program was started in the country, which care areas are targeted, and PC stands for preventive care and CC stands for chronic care, the quality dimension, whether it is targeting effectiveness or responsiveness, the types of indicators, whether it's process indicators, structure indicators, or outcome indicators, how the incentive is structured, whether it is a bonus or a penalty, and whether it is an absolute measure or a relative measure that determines the award given to the provider, the size of the financial incentive, and the type of provider and the number of providers targeted by the program. And what it shows in summary is that most programs are implemented at the national level, but there are some programs, for example, in Germany, Italy, and Sweden, that are regional, and about half of these programs in primary care are mandatory, while the other half are voluntary. Almost all programs focus on both preventive care and chronic care, and they mostly focus on effectiveness, e.g. the compliance with guidelines, but several programs also include indicators for responsiveness. In terms of types of indicators, there's a focus mostly on structures and processes, but some countries also reward outcome quality. In fact, it's 6 countries that reward outcome quality. And then most programs, no, all programs really award bonuses, and almost always these bonuses are based on the absolute performance and not on the relative performance compared with the peers of other physician practices working in the country. Now, concerning hospital care, we identified 13 programs in 9 countries, and I want to give you the summary directly that also here most programs are implemented at the national level, but Italy and Sweden have regional programs, and most of these programs really are mandatory. In terms of quality areas, most focus on effectiveness, so similar as in primary care, but 7 programs also include indicators for safety, which is a larger number, and 5 also include indicators for responsiveness of care. And in terms of quality indicators, in terms of the Donabedian triad, there's mostly a focus on outcomes and processes, which is different from primary care, where the focus was mostly on structures and processes, and only 5 countries also reward structural quality in hospitals. And here, about 6 programs award bonuses and 6 programs award penalties, and almost always these are based on absolute performance, while a relative performance is not used in any of these countries. Now, after this overview about pay for quality programs in different European countries, I want to show you the results of a systematic review of reviews that we did to identify the results of pay for quality programs across countries. And we found that there are 18 reviews that are exclusively based on studies from the UK and the US, while 16 reviews also include studies from other countries. And there were 18 reviews focusing exclusively on primary care, 4 reviews focusing on hospital care, and 12 reviews that were not limited to a specific provider. And what they showed, the results on effectiveness of P4Q in primary care, there were 124 studies that looked at more chronic care indicators and 87 studies that looked at preventive care. And first, showing the results only for processes of care, there were many studies that found large positive effects in observational or uncontrolled quasi-experimental studies, but rather no effects or only small positive effects in the better designed studies, such as randomized controlled trials, interrupted time series analysis, or controlled before-after and other studies with a comparison group and longer time periods for processes of care. Concerning health outcomes, studies found mixed effects on diabetes-related hospitalizations and on long-term complications, as well as emergency department visits related to asthma, diabetes, and heart failure, depression treatment response, and on neonatal ICU admissions. And there were no effects in chronic care on all-cause mortality, 30-day mortality, readmissions, emergency department visits. And there were no effects in preventive care on quit rates or smoking prevalence. So these are the results on health outcomes in primary care. Related to hospital care, studies with a comparison group, first focusing on the processes of care, there were 30 studies of 15 P4Q programs, and studies with a comparison group usually found a small short-term and or non-significant effect on composites or of multiple processes of care measures, but positive effects for some individual indicators. So in general, there were no strong effects, but for certain indicators, studies were able to find positive effects. And studies without a comparison group often reported strong positive effects, for example, on breast cancer or acute myocardial infarction. Concerning health outcomes, there were 13 studies that included health outcomes, and they mostly found a short-term positive effect, but not in the long term, and the lower quality studies sometimes reported also positive effects. Now after this overview of the evidence on pay for quality, which generally shows that these effects are rather small or not sustained in the long term, is that there are several points to consider during implementation of pay for quality, and pay for quality is rather complex to implement, and there are different questions that need to be answered during the implementation of pay for quality. The first question is who to incentivize, so which providers to target, and how can one assure that most providers are included in the scheme, and there are different advantages and disadvantages of having a mandatory program, for example, or a voluntary program. There are other questions concerning what to incentivize, and in general, this should be a comprehensive approach that targets many different clinical areas of care and focusing on those areas of care where there are known quality problems, because these are the areas where then the greatest improvement can be achieved through a pay for quality program. Another question is how to measure and how to incentivize, and there the size of the incentive is of course important, and the design of the incentive, whether it is a penalty, a bonus, whether there is an incentive for attainment or improvement. And attainment, of course, provides a clearer message to providers what they have to achieve, while improvement may provide a larger incentive for continuous improvement over time. And finally, how to implement a pay for quality program. And there, the rule should be that this should enable systematic evaluation and periodic re-evaluation, because the effects during the initial implementation may be different from the long-term effects of the program. And it is important to periodically re-evaluate also to identify unintended consequences and adverse effects of pay for quality, and in order to be able to adjust the program. And furthermore, what is important during all of these stages is that all stakeholders should be involved, because only if the program is accepted by stakeholders, they will react in a way that leads to improvements of quality of care, while otherwise, if it creates opposition, it will rather lead to adverse consequences. This brings me to the conclusions, and these are that pay for quality is increasingly used in many European countries. There's very limited evidence from European pay for quality programs, except from the UK, and therefore it is important that if programs are introduced, they should be introduced in a way that makes it possible to evaluate these programs and to study what their effects are. The existing studies report mostly positive effects, but mostly for process measures, not for outcomes, mostly short-term effects and no long-term improvements. And mostly these studies are based on relatively low quality evidence, which means that there is no reliable evidence that in fact pay for quality is effective at improving the quality of care. The implementation is politically and technically complex, and it is important that program implementation is regularly evaluated in order to avoid adverse consequences and to be better able to know whether these programs in fact have positive effects. Thank you very much for your attention, and this brings me to the end, and this is again a picture of the first page of the chapter on pay for quality in the book.
I had in the meantime posted that it's chapter 14, and then I was thinking, I'm right? Yes, and I was right, it was chapter 14. Thank you very much. I think quite interesting, a lot of food for thought about the merits of such programs. We'll hear about this now from our spotlight speakers. I will be disciplined. There are already a lot of interesting questions in the chat. I won't ask them yet because I would like to, but I won't. I will keep them for the discussion as we promised. Well, what we will do now very briefly is look at the poll results. So Erica, if you could just give us a very short hint what's been going on.
Sorry about that. Yes, thank you very much. So yes, it's quite interesting. A third of the people who responded from the audience have said that P4Q mechanisms are not currently being used in their country. So that's quite interesting. Of the others, about just over a third are using them in primary care, about a third are using them in hospitals, and about a quarter are using them in other parts of the health system, which is also quite interesting. So that's something for the speakers to bear in mind when it comes to answering the questions. Thank you very much. Thank you.
Thank you, Erica. And I think we go to one of the countries that has experience with pay for quality measures. We go to Estonia. And so Kaya, we come to you for your spotlight to share with us the Estonian experience.
So firstly, thank you for the introduction and thank you for having me. I will now jump right into the content and provide you an example of the current Estonian QBS system, as we call it, but pay for performance system at the primary healthcare level. The main objective when it was implemented was to improve the quality, as we started with and with our today's main topic. But in Estonian context, you need to be aware that our primary healthcare system as such is a very young system, and a 5-year transition period to adopt like gatekeeping system, independent service provider network, and population enrollment were completed only in 2003. And if you see from the slide, the QBS we already started to implement in 2006. So after the primary healthcare reform that we had, we immediately noticed that we need a system to improve the quality in comparison of the implemented or basically to balance the mostly capitation-based funding that we had at that point and actually still do have. The most important objectives of the QBS was to improve the quality. Basically, we decided that there will be several domains, and these domains also reflect the objectives to reduce morbidity from vaccine preventable diseases, management of chronic diseases, and to basically one of the objective was very much related to the primary healthcare reform as such as well, because we wanted to expand the scope of services provided at the primary healthcare level. And this all reflected in the B4B design and in the 4 different domains. Only the most recently, the 4th domain was added about provider accreditation, and this process to add this component was mostly led by the Family Doctors Association themselves, who are very much interested in adding like a management component as such, which was previously missing. On the small graph, you can see the weights of different indicators and domains in relation to the payment. So overall, B4P is about 4% of the primary healthcare budget in Estonia, but in practice, it can rise over like a 1 month salary for a practitioner and a nurse. I will not go into the details of the details of all the indicators, because I will share with you later on also a document which you can read for the background information. But what I wanted to bring forward today is the main success factors that we consider in Estonia that were like crucial to have the system in place and to basically have it acknowledged by most of the stakeholders. So firstly, one of the main success factors is that the development of the QBS system was led by the Family Doctors Association. Naturally, it was jointly done with a National Health Insurance Fund, but there were very strong champions to drive the implementation and the clinical input. Therefore, the system was and still is widely accepted among the providers and family doctors. Secondly, the QBS helped to develop this kind of quality focus that we were not maybe used to before to that extent. So considering our historic background from the polyclinic-based system, at primary healthcare level, then developing this kind of pay for performance helped to bring the quality topics on the table, and it created this kind of quality focused culture among the medical staff as well. Then thirdly, the incentive payments and indicators in Estonia are mostly based on national clinical guidelines. As you can see on the slide, the example of the Estonian handbook for guideline development, and the topic that you very discussed on your previous webinars. But in Estonian case, we see that the QBS system as such raised the importance of developing actually the national guidelines, specifically having national guidelines available, and it increased their role in the healthcare system. And finally, the data. We realized that the efficient and easy data collection and monitoring system is crucial to implement the QBS system. So in Estonian case, we managed to adopt the system in a manner which didn't require any additional reporting. So we use already available electronic billing data. The electronic controls, there are electronic controls in the IT systems which check the data, and naturally we also have clinical audits and regular controls and comparison with medical records to ensure data quality. And also mentioning what was not less important is that all the providers and every physician received personal feedback, and they had the possibility to appeal for the results when they felt that something was missing, and this was all done electronically to make it easier for the providers and less burdensome. And all the results were published on the EHIF's website. So up to 2015, the system wasn't compulsory, but following then, the system has been compulsory, and for all the family physicians, the results are publicly seen. So very briefly, I think that these four major points, having providers, including creating like quality-focused culture, giving importance to national clinical guidelines, and also having this kind of data and data collection monitoring system in place. These were like crucial success factors for, at least for our QBS system. So very fast, I believe that was all I wanted to go over today. I will put some links in the chat where you can look at the most recent studies. And so thank you, and I will be looking forward to the questions already.
Thank you very much, Kaya. Just to point out for our participants who asked, it was one slide and it had different quadrants where the content was organized. In the interest of time, Kaya didn't prepare a lot of slides, just that. And thank you also very much, Kaya, for linking to the previous webinars. We'll come back to that later on. But now, without further ado, we go over the Atlantic to the United States and to Robert with your experience. A little different, I would say.
So I have one slide also, and I've become quite negative about pay for quality. Or we talk more generally about pay for performance. We also talk about public reporting, because one of the purposes of public reporting is to move market share, that patients would go to higher performing or higher quality providers. And so that also is about giving them financial incentives. So I've put my first bullet, public reporting and pay for P or pay for Q. I want to first just basically summarize the US literature. It's actually the universal literature, the same literature that Wilm reviewed, but I'm going to quote Elizabeth McGlynn, who was very responsible for the quality chasm report by the Institute of Medicine 20 plus years ago. She summarized the state of the performance the performance of various measure approaches in a New England Journal of Medicine article in 2020. Despite nearly 2 decades of experimentation with standardized measurement, public reporting, and reward and penalty programs, average quality performance remains about the same. In other words, all of this effort in the US, it's been going on for 20 years, has not really changed quality for the better. Wilm has talked about the concerns of compromising professionalism. It's interesting that back in around 2003 or so, there was a New England Journal of Medicine editorial that said that that pay for performance had compelling logic, and that was generally accepted. But 8-10 years later, the behavioral economists started weighing in and raised serious concerns about the compelling logic, that if you turn professionals, even if a lot of them are not acting very professionally all the time, you may convert what professionalism they have is to simply responding to a handful of measures, and their overall quality might decline. We don't have good evidence about that, but it does raise the question of whether this is even conceptually a good idea, at least for individual clinicians. It may be a little different for organizations like hospitals. But I'm going to focus my couple of minutes on operational implementation issues. There have been some positive anecdotes. There are some articles that are positive, some stories you hear about how important the pay for quality was in motivating behavior. But overall, operationally, the experience, I'm going to argue, has been negative. And I've summarized my views in an article that somebody promised they would put into the link into the chat box. Just very briefly, the use of unreliable, invalid, or trivially important measures, and I can provide examples of all of this in discussion if we have time. Turns out that the statistical analysis of performance can be very complex and controversial. How do you draw inferences about performance with a whole array of data about any individual organization like a hospital or provider? It's not straightforward. But I'm going to spend most of my brief time here talking about 2 things that get very little attention. Wilm did not review this, and I don't think there's much literature about this. High implementation costs and high opportunity costs. There was one article from Health Affairs by Larry Casalino and his colleagues in 2016, based on surveys of physician practices, getting actual time spent on providing measurement that are part of pay for quality programs. And they concluded in their analysis, I think using 2015 dollars, that physician practices were spending over $15 billion a year just providing the data for pay for quality programs. If you include, as the US does, that hospitals, nursing homes, hospices, Medicare Advantage plans, those are private insurers in Medicare, and a whole raft of other providers are also providing that data. If you include the costs that the payers bear implementing their part of pay for quality, it's probably less than a single payer system, but in the US, we obviously have lots of payers. And then there's a whole industry. It's called let me see if I have this right, the measurement industrial complex, taking advantage of what President Eisenhower once talked about with the defense industry. There's a whole industry now of people who are in the business of measuring, collecting data, having registries, et cetera. If you take the Casalino data and do just modest extrapolation to all of these other participants, I am guessing, and it's a pure guess, that the US probably spends about $50 billion a year on this enterprise. Now, 50 billion might be considered not so much because the US, everybody knows, spends outrageously in healthcare, but I did the math the other day, and it turns out it's a little more than 1% of our health spending is going on the implementation of pay for quality programs in the US. And that's, again, it's a guess, but I bet it's not far off. And then the other thing which gets very little attention are the high opportunity costs. And I want to start by quoting from a practicing physician who wrote an article in Health Affairs 2 years ago. Her perfectly constructed sentence is the following. Ironically, metrics-based programs can undermine quality improvement by shifting resources and attention to measurement and reporting and away from actually improving care. And I think that is what's going on. There's such a preoccupation with complying with the requirements of P4Q programs that other approaches to improving quality, which I'm sure are all detailed in the European Observatory book, are given short shrift. And I will conclude with just one very concrete example of where I think this is manifest. In the US, we've been, the CDC calculates the control of hypertension in the population. And in fact, blood pressure control has actually declined from 54% in 2013-14 to only 44% in 2017-18, which in turn is 5 percentage points below that reported in 2007. So we've actually declined in our control of blood pressure over the last 15 years substantially. We're now well less than half of the population has their blood pressure under adequate control. And what's also been going on for the last 15 years? We've been including blood pressure measurement in virtually every pay for quality program that anybody administers. This is not cause and effect. I understand that. It's a very negative association between pay for quality and actually improving quality. And I would argue that there are other approaches, for example, to promote quality improvement programs, to introduce new practice guidelines based on recent evidence that most clinicians in the US are unaware of about the best way to manage high blood pressure. And we don't do that because we are so committed to this failed enterprise called pay for quality. With that, I will pass the baton. Thank you.
Thank you very much, Bob. And I think that was quite a strong concluding sentence there. And I hope we will have time to come back to that in the discussion. Again, I'm very tempted by all the things that I see popping up in the chat to link them directly to what you were talking about. And I will do so if we have time during the discussion later on. Let me pass on to our last spotlight speaker for some insights from Athens. Joao, over to you.
Thank you very much. Delighted with the invitation. I have a few slides I would like to show. So let me know if you can see them. Our office is new. It was initiated last year here in Athens, but yesterday we had a very important day because we formally opened the facilities of the office with the presence of 5 ministers and the Prime Minister of Greece. So a great support for this new Center of Excellence on Quality of Care and Patient Safety based here in Greece. We are still in the first steps of implementing of this initiative, but we have a very clear vision. It's a vision of decisively improving quality of care and patient safety in the context of the WHO European Program of Work and focusing on reducing inequalities while promoting innovation and health leadership. This for us is kind of really the inspiration from the vision of the office. We also acknowledge that quality in the WHO European region has improved quite significantly in the last decades. It's a very heterogeneous region, and there's really very significant difference between the different parts. But clearly, this is an example on the premature mortality due to major non-communicable diseases. As you can see that obviously quality improvement has contributed a lot to the decrease in premature mortality. Obviously, these achievements are not attributable exclusively to financial incentives, probably more important to other reasons and other areas of action, but a combination of quality care policies and interventions are decisively important, and this slide really showed that quality has improved according to these systemic implementation of probably different evidence-based policies. So when we think about financial incentives and quality of care, what do we know? And we're trying to build on this as we trigger our work in the region and really looking forward to become the center of excellence and working with stakeholders and colleagues from other parts of WHO, including my colleagues from the Observatory. We agree on the fact that based on the evidence, the effectiveness of providers' financial incentives, it really remains relatively unclear and inconclusive. It was shown really just before that the design of the incentive programs really matters. What are the priorities? Do we have a large enough scope? What is the size of the incentives, penalties? All of this seems to be important for the final results. And clearly, as it was said before, we do agree that some undesirable effects on patients' preferences have also been noticed and identified. Inequalities in health and access to quality of care persist in Europe and cannot be addressed only through modifying providers' payment systems. We are very much aware of this, and we agree really with the statements made before also in this context. So as we move forward, let's say one of the core elements of WHO that WHO can bring into this discussion is really working with countries. So moving forward, supporting countries, there are three focus areas where we would like to work more in the future with many of the stakeholders that probably are following this discussion and also some of the speakers and their teams and their institutions. Really focus on approaching quality from a systemic perspective. Innovative and integrated interventions, new models of care, quality improvement initiatives, transparency, and above all, addressing health inequality, cultural and behavior change. These are important elements that need to be included in this equation of addressing quality from a systemic perspective. Really focus on health outcomes and value, expand from qualitative inputs and processes to improve health and experience of care. This is also one of the areas where we would like to contribute to the discussion and to the support to countries in the near future. And last but not the least, focus on evaluation and digital. Value of healthcare requires new assessment frameworks and investments in health information systems to capture patient-reported data systematically. Not that this become a huge cost in terms of the measurement itself, but using those measurements in a simplified but effective way so that we can really move forward. Harness the power of the digital and quality is very important, very much on our agenda. So I think I would stop here. This is our contribution to the discussion. Very much for looking forward for any questions you may have. Thank you.
Thank you very much, Joao, also for the excellent timekeeping. I think very important, the second point that you raised on the last slide, which is focusing on outcomes. And I think the discussion that we've been having is that, if you want to use financial incentives to boost outcomes, you might want to be careful how you go about it because of the different experiences that we see. Thank you very much. I think this was our last spotlight presentation, and we now have about 10 minutes left for discussion. So what I would like to do is to go to Erica to give us a summary of what's been going on in the chat. There were quite a lot of interesting questions about value-based healthcare I saw in different dimensions. So give us like the main tenets so that we can use the best that we can the last minutes that we have.
Okay, so there was quite a lot of interest in the links between paying for quality and value-based healthcare. Wilm has jumped in and sort of unpicked the terminological issues there. So we don't need to focus on that unless you particularly want to. There was a question about the impact of whether there are different impacts depending on the type of payer on the quality outcomes. So is there an impact by, for example, purchasing power, so whether it's regional or national body doing the purchasing? But a lot of the questions are much more about the ethics and politics of this. So how can you keep politics or even, dare I say, corruption out of the system when it comes to choosing which outcomes you're going to choose or which providers you're going to choose. How do you actually keep that out of the system? And following on that, when you're talking about the ethics of paying for quality and the impact on professionalism, when you're discussing it with policymakers and you're choosing your process indicators for things such as patient safety, how do you do it in a way that you don't sort of bring in all these sort of warped incentives that undermine professionalism? And of course, there's the eternal question about opportunity costs of collecting all the data necessary to actually do P4Q. So if we start with those, I'm sure more will come up in the box.
Quite a range, Eric. I think I saw one last thing that popped up while you were talking, so maybe you haven't seen it yet, which is about the application of this in resource-constrained settings, because the US has quite a spend in healthcare, for healthcare, as Bob was saying. I know, Wilm, you've had some experience with working with countries on this, so perhaps let's think about the politics and corruption first. I think keeping incentives not worked, and then perhaps the issue of resource constrained settings as well. So I think based on the input so far, all of you would have a lot of inputs on this. But Wilm, maybe we start with you, then we go to Bob perhaps, and then to Kaya, and then to Joao last but not least. Wilm, over to you. Any first reactions?
So on the effects in low-income settings, maybe I start with that. I would say it's much more difficult even in low-income settings because the data that is available in order to measure quality is much worse and much less available than in high-income countries. And therefore, that makes implementation of a P4Q program even more difficult and more constrained only on certain indicators that can be easily measured, which reduces the potential effect and also increases potential adverse effects, I think, of P4Q. Concerning political influence, I think my thoughts would be that, in fact, it is important to include stakeholders in the process. And I mean, therefore, I'm not sure what political influence, political influence can be many different things. I think on the one hand, it is important to include stakeholders in the development of the program, because only if they are convinced that it is a useful program, and if they kind of sign up to the idea of the P4Q, and if they feel it is a way of supporting them in developing quality improvement strategies, it will have the effect of improving quality of care. So I would rather say that it is important to involve stakeholders in the development instead of, but of course, in a way that doesn't lead to certain provider groups getting more money for unjustified political reasons. And maybe I stop here in view of time.
Yes, and then I ask Bob if he agrees. I think Wilm won't be upset. You can disagree. I think it's fine.
No, I do agree. I'm going to try. I'll give an example of where politics sort of enters into this whole thing. The Congress passed this major legislation in 2015 called MACRA. I don't even remember what the initials stand for anymore, but it was going to create what's called a merit-based incentive payment program, which was P4Q, actually. It was all about quality metrics, not really spending metrics, and it was very ambitious. If you did poorly or didn't submit your data, you could lose up to 10% of your revenues, and if you were the big cheese, the big winner, you could get as much as 30% or so bonuses. And it turned out, I'm not going to go through any of the details, that there was no there. The program was not well conceived. And in the end, CMS, the agency that administers the Medicare program, decided to exempt 500 to 600,000 physicians, the ones who would have lost, because the winners were all the big, large multi-specialty groups. The losers were the onesies and twosies But instead of penalizing them 10%, the agency figured out, well, we will exclude them because they found a reason that they don't have enough volume for statistically significant. They found a good cover. If I were still at CMS, I once was at CMS, I would have done the same thing. It was that you were going to have a revolt from US physicians. And in fact, the prior legislation actually called for ranking every physician in the country based on their quality, based on 6 metrics. They actually had the gall, the Congress did, to think that that could produce an objective, valid measurement of every physician. And that obviously was a non-starter. So to me, the politics in the US is largely that P for Q has this great aspirational, compelling logic, and it helps politicians decide, I mean, to give them sort of say they are acting decisively to improve quality, but there's no there, as I've used before, it doesn't work. And so my conclusion is that you have to be very sort of narrow. There are niches in which P for Q can work, but as a central philosophy of improving quality, a central approach, I think it's inherently flawed. And I will just make one other thing. Usually after my presentation, somebody inevitably says, but without measurement, how can you improve care? And I want to just be real clear. Measurement for internal quality improvement is absolutely necessary. Measurement for public reporting and P for Q is what I'm saying isn't working well.
Thank you. A very, very important clarification, I think, Bob. And so I take the point, and a very nice concluding bit, I think, as well, to keep in mind for the end of the webinar. Having said that, we still have Kaya and Joao, and my pay for quality measurement for myself is whether I manage to end these webinars on time, and I don't ever get paid, let me tell you. So let's try to keep this brief. Kaya, we come to you, then we go to Joao very briefly, and then we close for today. Kaya, over to you. I think you need to unmute. Yes, now.
Yes,
perfect.
Sorry. So regarding the different country contexts and different settings, low, middle, high, since I've been working in plenty of middle income countries as well, very practically on primary healthcare level, then I do feel that you need to look into country contexts to validate what is the level, because that's why I started my presentation with actually reflecting on where we came from, what was our system like. There was nothing to discuss about the quality at that stage when we started with the primary healthcare, and therefore we quickly needed something to very much incentivize quality related activities. So this, I feel like this was at that time, it was very much in place in Estonia, and I feel it's very relevant in many of the low income settings as well, middle income settings, and regarding data monitoring for these kind of countries is that if you don't, naturally there is no data. If there's less data in this country, the first step is to start to monitor this data. A lot of these countries have been trying to do this, but if it doesn't work out, then you need to incentivize somehow the data collection mechanisms. So this is the one tool that you actually can use for this. As for political influence, to be very short, there have been plenty of discussions in Estonian case as well. What is the political influence of the QBS system? And we have a very strong Family Doctors Association bringing this all forward, and then on writing on this topic, being like the only quality related system still in Estonian healthcare compared to other settings. So there's definitely this kind of political influence involved, but also the country's health policy priorities. So this is something that the ministries or policymakers need to make clear themselves. Where are their priorities? Where should they implement these incentives, agreeing already with everyone else as well, that they need to be thought through well when implemented, and also monitored that they actually achieve the final policy goals that have been put to them in the beginning. Thank you.
Thank you very much, Kaya. Joao, over to you. You have -3 minutes.
No problem. I mean, I would just say it's always a political choice, isn't it? So we need to make sure that it's transparency, right? So that the decisions are made thinking about the citizen and ultimately the patients. And there's always political choices to make. And that's very important that we link it with transparency. New information systems, new ways of looking at data. Of course, sometimes more difficult to find data in certain countries, but there are also novel opportunities to look into data that we haven't used before. So here we also need to innovate. And based on that, really ensure that we have transparency addressing inequalities. That would be my point here. Thank you.
Thank you very much also for the brevity. A very final thing, I think, coming from all the things that we have heard, this is maybe a tricky one when it comes to deciding if and how to implement. We heard that there are certain areas where it can work. We heard that stakeholder involvement is important, and we should see it as part of an overall strategy on quality with different mechanisms, perhaps not as the sole strategy. We've been talking about this throughout our webinars, and we heard also how it can incentivize maybe also other mechanisms like clinical guidelines or maybe even data reporting. So seeing it in context by also understanding the limitations and the opportunities is very important. And I thank all of you very, very much for giving us this very rounded view of Pay4Q as an instrument, and for being part of the final webinar in the Spotlight series on quality of care. And with that, we close, not even 5 minutes too late. Thank you very much, everyone, for being here, and hope to see you again very soon. Very final point for those of our participants who are here. We have an evaluation of the series on quality that you can click on now at the end of the webinar if you are still here. We're very grateful to everyone. See you soon.